Welcome to SARC Talk Journal Club, where we take a closer look at the research shaping the future of sarcoma care. In each episode, we'll discuss recently published studies, break down the findings, and explore what they mean for clinicians, researchers, patients, and advocates. Along the way, we'll be joined by experts from across the sarcoma community and sometimes even the authors behind the research. Whether you're keeping up with the latest science or looking to better understand the evidence driving sarcoma care, we're glad you're here.
Welcome to SARC Talk Journal Club, episode number 3. Today, our article that we are describing is from Dr. Brennan et al. In the British Journal of Cancer from 2026. It's the addition of zoledronic acid to consolidative chemotherapy in Ewing sarcoma. I'm here with my co-host, Dr. Catherine Wilbur, sarcoma medical oncologist at Johns Hopkins. Please welcome Dr. Wilbur. Catherine, good to see you again.
Thanks, Scott. It's nice to see you too. Nice to be here as we're moving on to our 3rd episode.
Absolutely. We've had a lot of fun doing these episodes, so why don't we hear our thoughts on this journal article?
Perfect. So I'll launch into a bit of background to start with. We'll be talking today about Ewing sarcoma. And so it's a sarcoma predominantly of the bone, so occurring 80% of the time in bone and about 20% of the time in an extraosseous location. It's really defined by these FET, ETS fusions, so the majority being EWS R1, FLY1. And as we think about treatment for Ewing sarcoma, it's pretty intensive therapy. So really multimodal with chemotherapy, with surgery and or radiation. Generally, we are seeing Ewing sarcoma in our kind of adolescent and young adults, with a peak then again for that second peak in the 20s. For localized Ewing sarcoma, we do see that 3-year event-free survival of about 65% and that overall survival of 75%. When patients then have metastatic disease, if they have only pulmonary metastases, we do see a 3-year overall survival around 68%. But if patients have metastatic disease in sort of multiple different places, then that overall survival at 3 years really drops quite significantly to about 29%. So thinking a little bit about, we'll be talking about zoledronic acid, but it's bisphosphonate. It is used in multiple cancers for bone metastases. So, in the adult world, we see it used in breast cancer and prostate cancer, and really it inhibits the resorption of bone and sort of tries to protect the integrity of bone. The investigators here had looked at zoledronic acid and how it affected Ewing sarcoma both in vitro and in vivo. So while it was in vitro, the combination was actually, the inhibition was enhanced by alkylating agents. And then in the in vivo models, there was a pretty strong inhibitory effect on bone Ewing sarcoma with that synergistic effect with ifosfamide in the soft tissue models. Overall, zoledronic acid is pretty well tolerated, so a low toxicity profile in both children and adults. And at the time of this study, there were no prior randomized controlled trials of zoledronic acid in Ewing sarcoma. There was really only one case report at that time. So all of that led the authors to hypothesize that adding zoledronic acid to consolidation chemotherapy would improve clinical outcomes for patients with newly diagnosed Ewing sarcoma compared to consolidation chemotherapy alone. So this, again, was the EURO EWING 2012 study. This was a randomized trial, and there were actually 2 different points of randomization. We actually are going to be talking about the second randomization today in this trial, but just to briefly kind of go through, the first randomization was looking at the induction chemotherapy regimen. So patients were randomized, either to vincristine, ifosfamide, doxorubicin, etoposide, or vincristine, doxorubicin, cyclophosphamide, ifosfamide, and etoposide. And then at that point in time, they were also given sort of their randomization to their consolidation regimen. So again, complex study design here, but we're really talking about that second point of randomization after patients had completed their induction chemotherapy. So patients at the point of R2 that are or second randomization, they were randomized to either zoledronic acid with their chemotherapy, consolidation chemo, or no zoledronic acid. And they were hopeful to get 400 patients or 200 patients in each arm. The randomization was sort of 1-to-1. This again, that when we think about the study design, this was a randomized, phase 3 trial. This part was enrolling in 10 countries at 110 different sites. And again, as we spoke just briefly about, there were two kind of randomizations. In order to be eligible for the trial, patients had to have, histologically confirmed Ewing sarcoma or Ewing-like sarcoma, and then they had to have their fusion confirmed as well, even though EWSR1 negative, Ewing-like was also eligible. At the point of the second randomization, which is the part of this study, patients had to be ages 5 to 49. They had to have responded to induction chemotherapy. They had to have planned consolidation chemotherapy per protocol, and then they needed to be medically fit for zoledronic acid. We'll get into the primary endpoints here in just a second, but sort of thinking about the statistical considerations, they were hoping to enroll a total of 800 patients, so 400 patients per arm. And this was going to be in combination with the concurrent Ewing 2008 trial that was going on in Germany at the time. That was also looking at the role of zoledronic acid. But for this particular trial, they wanted 400 patients, so 200 to each arm. And then they really had designed this to detect an absolute increase of 8% in the 3-year event-free survival. Sort of the alternative way they were looking at this is that if they had they would need 500 patients required to detect a 10% increase. The primary endpoint was event-free survival. And so again, that was defined as the time from randomization to first event, where the event was progression without complete remission, recurrence following a complete remission, diagnosis of any secondary malignancy, or death by any cause. The secondary endpoints were overall survival, adverse events and toxicity, growth parameters, given they were looking at height in patients who were less than 18 years old, and then the incidence of jaw and ear osteonecrosis. As we look at our results, there were a total of 272 patients who were randomized for this portion of the study. And so 136 received zoledronic acid, 136 did not receive the zoledronic acid. The characteristics between both cohorts was pretty similar. So the median age was 15. There was a slight male predominance, 58% in the zoledronic acid, 59% in non-zoledronic acid. They did kind of break it down by localized disease, either good risk or poor risk after induction. So we did see 42% had good risk in the zoledronic acid, 43% good risk in the non-zoledronic acid. And then for poor risk, it was 21% and 24% in each cohort, respectively. About 19% within both cohorts had lung or pleural pulmonary metastases. And then it was pretty equal in terms of the patients who had been allocated to either VIDE or VDCIE within the first portion. So this study, unfortunately, did not meet its primary endpoint. The 3-year event-free survival was 59% in the zoledronic acid arm, and then it was 57% in the non-zoledronic acid arm. There was also no difference between the subgroups. So as we look at these subgroups here, there certainly was sort of a trend towards that difference as we looked at age, but nothing that was truly statistically significant. And then, nothing else within the subgroups that was significant. There also was no difference in overall survival. So the 3-year overall survival was 75% in the zoledronic acid cohort, and then 75% as well in the non-zoledronic acid cohort. And then pretty similarly, we did not see any significant, differences in that subgroup analysis. So sort of regardless, and the authors had looked at again that R1 treatment allocation, good risk versus poor risk, where their metastases were, what country they had been in. As we looked at the safety profile, so the authors gave us sort of adverse events grade 3 to 5. Again, that was also fairly similar throughout each of the AEs, aside from hypophosphatemia. So with the patients who received zoledronic acid, 10% or 14 patients did develop grade 3 or higher hypophosphatemia, compared to 5 patients or 4% in that non-zoledronic acid group. There was one patient that did develop osteonecrosis of the of the ear, but no patients in either cohort developed osteonecrosis of the jaw. And then, as expected, sort of with consolidation chemotherapy, there were similar rates of febrile neutropenia, decreased neutrophil count, decreased platelets, anemia, and so sort of what we would expect as these patients are on consolidation. As we think about the key takeaways, the primary result is that adding the zoledronic acid to consolidation chemotherapy did not improve event-free survival or overall survival. But the safety profile was pretty manageable. There really were no excess rates of any hematologic toxicity, jaw osteonecrosis. There also was no impairment on growth. So that was something that they had been following as a secondary endpoint. There was, slightly more hypophosphatemia in the zoledronic acid arm, 10 versus 4%, and then again, the one case of ear osteonecrosis. There were some limitations of this study. It was underpowered. Again, they had aimed for that target of 800 patients or 400 within this study, and they had only enrolled 272. The authors do mention that was probably due to a couple of reasons. Number one, the superiority of VDCIE within the first randomization was shown. And so that enrollment was stopped early just due to that finding. And then there were a number of patients or physicians that declined to actually be randomized for the second part for zoledronic acid. And the authors think that is likely due to the fact that the treatment was extended. And then, I think the other limitation is that the preclinical data we saw really did not kind of translate into our clinical benefit. But there certainly are hormonal factors that may partially sort of explain that lack of efficacy that we observe.
Absolutely. Dr. Wilbur, as you think about it, in this study, after aggressive chemotherapy, local therapy, did the randomization, and it didn't require 9 monthly infusions of zoledronic acid. That's it's not intense per se, but that's a lot of extra commitment, as you would say. And as you look about the primary takeaway, was there any discussion or thoughts about why they didn't randomize up front during the induction, or they only took after you finish treatment, we're in the consolidation phase?
Yeah, so they had, a separate set of eligibility criteria for that second randomization. So, they certainly wanted to make sure that it was appropriate for patients to continue on to consolidation and then that randomization. So, they had to have, essentially tolerated, responded to induction, and then really be appropriate to move on to consolidation therapy.
Yeah. We've been always trying to improve upon the standard chemo for the last 20 plus years, and it was worth, rational to kind of consider bisphosphonate in this space here. But overall, at this point, what would be the major questions that are still unanswered as we move forward?
Yeah, I think there are a few questions. One of the major questions is what effect did age kind of play in this, right? We certainly see that sort of the peak, sex hormone steroid activity is right around the age of 15, because in the other cancers, the malignancies that we're seeing the benefit of zoledronic acid, in breast cancer, for example, those patients were all postmenopausal. So, certainly low activity at that point. And so I think that's something to consider, and I would hope that we would get sort of a better sense of that. Within the kind of parallel study that they wanted to combine with, right, the median age within that trial that also did not show a benefit of zoledronic acid, that median age was 15. I think kind of other questions, right, is, will the data ultimately be combined? So the Ewing 2008 with this current trial. And then are there any predictive biomarkers, for zoledronic acid response? Like, can we look at sort of the pathway and determine if that might give us some sort of insight? But I think overall, right, this trial showed us, how important this sort of international collaboration is for Ewing sarcoma, especially given sort of the rarity of disease.
Yeah. Even though it did not meet the number of patients that they wanted, I think they had 126 on each arm. There was no subset that looked like they benefited from the treatment. So at this time, zoledronic acid in consolidation with consolidative chemo probably is not something that we should be offering our patients. What's your thoughts?
No, I agree. I think, we've seen through this trial and then the one prior trial, right, that we don't have a benefit. And I think it's certainly tough to make the argument to sort of, continue treatment for longer, right, for these kind of patients that do have a pretty intensive, treatment course. So I agree with you there.
Even though it's a negative study, it was a lot of effort, and we applaud the groups that did do this study. And at this point, if anybody has any questions about this article or this Journal Club episode number 3, please let us know. But at this point, we would not be using the use of zoledronic acid in consolidation. And again, I think it was Dr. Bernadette and the colleagues there that did present this in the British Journal of Cancer in 2026. So check the article out if you have any additional questions. Dr. Wilbur, thank you again for an outstanding Journal Club today. Any of the final comments on our 3rd Journal Club?
No, thank you. I think this is great. Really interesting investigation, and then I'm happy we got to go through the data.
Perfect. So thank you. We look forward to everybody else returning for SARC Talk Journal Club episode number 4 in the future. So thank you.
Thank you for listening to SARC Talk Journal Club. If there's a publication you would like us to review or a question you would like us to address, we would love to hear from you. Leave a comment or email sarctalk@sarctrials.org. Be sure to follow the podcast, leave a review, and share this episode with others in the sarcoma community.